Welcome everyone to the Comprehensive Neuroanatomy Educational Program, Module 4. Today we have our 19th webinar, where we have Professor Mahdi Darmoul, Professor and Head of Department of Neurosurgery at Monastir University in Tunisia, and he is also Vice President of Tunisian Neurosurgery Society, President of Maghrebian Federation of Neurosurgery, and President-elect of Pan-Arab Neurosurgery Society. He will talk today about WFNS Metastatic Spine Tumors recommendations. And as chairperson today, we have Professor Dr. Riaz Ahmed Raja. He is Vice President of the Pakistan Society of Neurosurgeons, Senior Consultant, Neuro and Spine Surgeon, and Neurosurgery Head of Department at Al Jamhouri. Yes, I think it's not correct. And he is also Vice President of the Pakistan Society of Neurosurgeons. So, Dr.
Liaquat University of Medical Sciences, LUMS.
Yes. Please, Professor.
Thank you so much, Dr. Ahmed and Dr. Mahdi, for joining us and prepared to present the case, your topic of the spinal cord tumors. So let's start.
Okay, thank you very much for your kind invitation. Dear dear Chairperson, Dr. Riaz Ahmed Raja, dear Dr. Ahmed Al-Jaradi, dear participant. I will talk about WFNS metastatic spine tumor and the recommendation of the spine committee, WFNS spine committee. You know, actually, with improvement in immunotherapy and other medical treatment, have led to longer life expectancy in conservation. This has led to an increase in the incidence of metastatic spine tumor, and spine metastases remain the most common type of spine tumor. Spine metastases are a significant concern. You hear me? Hear me?
Yes, Professor, we can hear you well.
We can hear you.
Yes. Spine metastases are a significant concern for patients with advanced cancer. They occur in up to 70% of cancer patients with the vertebral column being the most common osteocyte. And the most common primary cause are breast, lung, and prostate cancers. An approximate 10% of patients with vertebral body metastases eventually develop spinal cord compression and can potentially cause severe permanent disability. Pain is the most common symptom, followed by motor deficit. Bowel and bladder dysfunction is noted in nearly half of patients. Treatment concerns the primary cancer and the spine lesion, and an effective treatment for spinal metastasis should be able to achieve pain relief, tumor control, prevention of neurological compromise, and treat instability. Before planning the treatment, 4 points must be defined: the life expectancy, histology, clinical presentation, stability, and deformity of the spine. And the treatment should be done with a multidisciplinary team, because we have multifactorial treatment like pain management, surgical decompression, stabilization, radiotherapy, physical therapy, radiofrequency, percutaneous augmentation, and multi-TID treatment. And actually, the separation surgery combined with stereotactic radiosurgery is an effective treatment for spinal metastasis. The main symptom for spinal metastasis are pain, and we have local pain due to periosteal stretching and due to the tumor growth and invasion of or enlargement of the venous plexus due to outflow compression. We can have mechanical pain due to weight bearing, and it is signal of an impending instability. And also we can have radicular pain due to the involvement or compression of the nerve roots, and can also occur due to pathological fracture. Here, the pain is explained by the compression of the nerve root causing radicular pain, engorged veins causing local pain, periosteal stretch causing local pain, and spinal instability causing mechanical pain. The global treatment options are surgery, and actually we have the separation surgery, stabilization, and radiotherapy. And the separation surgery is an innovative technique actually which aims at circumferential decompression of the spinal cord and nerve roots to preserve nerve function while also restoring lost function. In addition, it creates an ablative target for radiation by providing a safe distance between the nervous tissue and the tumor, like here in this diagrammatic representation of separation surgery. Restoring stability is one of the primary goals of spine surgery for metastatic illness, and the patient with potentially reversible instability will benefit from surgery, especially patient with pain if pain exacerbated by movement, vertebral body collapse of 50%, or in case of moderate deformity. And the risk factor of anterovertebral instability are axial rigidity, location of metastasis within the anterior third of the vertebral body and the sagittal plane, or middle third in the axial plane, tumor size, decreased bone density, dorsal location of metastasis within the vertebral body, destruction of the costovertebral joint, upper spine location, and posterior element destruction. Spinal instability is a crucial consideration in the management of metastatic vertebral tumor, especially metastatic spine tumor, and several scores have been applied. However, the spinal instability neoplastic score is actually widely accepted and used, and is the most commonly used determinant of instability in metastatic vertebral tumor. And we have here in this score 6 items. The location, we have the location of the tumor, junctional in the mobile spine, semi-rigid spine, rigid spine, the pain relief with the recumbency and or pain with movement, loading of the spine, bone lesion, lytic mixed plastic, radiographic spinal alignment, subluxation, translation, present de novo deformity, normal alignment, vertebral body collapse, more than 50% collapse, less than 50% collapse, no collapse with more than 50% body involved, none of the above, and posterolateral involvement of the spinal element, facet pedicle or craniovertebral joint fracture or replacement with tumor, bilateral, unilateral, none of the above. If the score is between 0 and 6 are considered stable, between 7 and 12 are indeterminate, and between 13 and 18 are considered unstable, and we should consider surgical consultation if the score is superior or equal to 7. The goal of the treatment, the management of spinal metastasis, is most often palliative, and the primary aim being preservation or improvement in quality of life. The aim addresses pain management, relief of neurological deficit, and regaining ambulatory status. So, a multidisciplinary approach involving chemotherapy, radiotherapy, surgical management, and palliative care becomes necessary. And the treatment depends on the location. The surgical option for cervical and craniovertebral junction metastasis vertebral tumor. The surgical indication are cervical spine metastatic tumor should be treated with palliative surgical principle and multidisciplinary. Most patients with metastatic tumor of craniovertebral junction and subaxial spine can be managed with radiosurgery regardless of tumor histology or radiosensitivity. Innovation in radiation oncology techniques such as stereotactic radiosurgery are valuable adjunct to surgical management. Surgical indication for cervical metastatic disease are significant instability, progressive neurological deficit, intractable pain, and prior radiosurgery that reached spinal cord tolerance. Many surgery in craniovertebral junction and cervical spine are done mainly for instability, and the radiological instability criteria for craniovertebral junction are odontoid fracture with an athlon to axial displacement larger than 5 mm, displacement exceeding 3.5 mm, and angulation more than 11 degrees, Instability criteria for the subaxial spine are displacement exceeding 3.5 millimeter and angulation more than 15 degrees. The surgical technique in the cervical spine for the craniocervical junction C0, C1, and C2, posterior approach with stabilization can be preferred, and neurological dysfunction in upper cervical tumor results more from spinal instability than from the direct tumor cord compression, and occipital cervical fixation alone is most often sufficient. For the subaxial cervical spine, anterior technique are recommended. For the cervicothoracic junction, anterior or posterior approach can be used. And in the case of circumferential disease and low bone quality in subaxial cervical spine and cervicothoracic junction, combined anterior or posterior approach would be considered. In general, the junctional area of the cervical spine, occipitocervical and cervicothoracic, will commonly need surgical stabilization. What are the complications of surgery? Anterior approach tend to have higher complication rate, and especially blood loss and with transfusion requirement, also seen in thoracolumbar posterior instrumentation and decompression. And cervical spine tumor have the highest rate of pulmonary complication and multiple perioperative complication. The outcome, patient with metastatic disease to the cervical spine have poor outcome with an average survival of 15 months. Prognostic factor for postoperative overall survival were primary tumor histology, preoperative disease, progression status, postoperative radiotherapy, and adjuvant therapy. Surgical treatment plus adjuvant therapy achieved sufficient local control during postoperative follow-up. In a study of cervical spine metastases, the author concluded that surgical resection of the metastases and stabilization of the spine result in decreased pain intensity, improved quality of life, and in some cases, reduced neurological deficit. In another study, the author concluded that palliative surgery for cervical spine metastases improved the performance score and quality of life, but a cervicothoracic junction lesion should be a risk factor for poor outcome. What are the surgical option for the thoracic, lumbar, and sacral metastatic vertebral tumor? The presence of spinal instability and associated mechanical pain are defined as defined by the CINSE criteria, require some form of stabilization regardless of tumor histology. Those with highly radiation-sensitive metastatic tumors, such as lymphoma, multiple myeloma, small cell carcinoma of the lung, and germinoma, can be treated with radiation, chemotherapy, targeted therapy, as well as steroid, even in the presence of significant radiologic epidural cord compression, if the patient neurological condition is stable without surgery. Spinal metastasis with known primary, a patient with pathologic compression has without no pain, no neurological deficit, no instability, non-surgical care option must be applied. In case of significant instability and fast progressing neurological deficit, surgical with stabilization and or decompression can be applied. Here we have algorithm. The NOMS framework is a schematic illustration of neurological, oncologic, mechanical, and systemic decision from lower and R. If low-grade epidural spinal cord compression with no myelopathy, with radio-sensitive tumor, we can use conventional external beam radiation. And if we have with radio-resistant tumor, we can use stereotactic radiosurgery. And for high-grade tumor, high-grade epidural spinal cord compression, and with radio-resistant tumor, we should do separation surgery. For unstable lesion, we should stabilize. And if the patient is able to tolerate surgery, we should do separation surgery. If the patient is unable to tolerate surgery, we should treat by radiation therapy. Here another algorithm for spinal metastasis with known primary and pathological compression. In case of pain, if we have pain, only pain without we can do vertebroplasty or radiosurgery. And if we have no pain, we should apply for non-surgical care. For in case of neurological deficit, with instability, we should do surgery. Without instability, no non-surgical care. No neurological deficit, non-surgical care. The radiotherapy, especially stereotactic body radiosurgery, has replaced many surgery. Pure bony pain from diseased vertebral body will likely improve significantly with segmental fractionated radiotherapy and multifractionated radiotherapy. Palliative radiotherapy alone is likely to stabilize or enhance neurological deficit for a large percentage of patients with spinal cord compression. Radiation may create some risk. Vertebral compression fracture after radiation are more likely in pathology other than breast and prostate. Vertebral compression fracture rate varies 12 to 22% by volume of the treated area receiving maximum radiation dose. And this is how to treat for asymptomatic patient without compression and without instability can be treated with radiation alone. For asymptomatic patient with more than 50% vertebral body involvement, junctional disease, lytic morphology, multi-level involvement can be treated by also radiotherapy and with serial imaging for vertebral compression fracture after radiation and may be considered for pre-treatment vertebral augmentation. For asymptomatic patient with significant cord compression should undergo decompression with instrumented fusion before radiation therapy. And for symptomatic thoracic and lumbar lesion, thoracic and lumbar metastatic lesion causing severe mechanical pain or instability require posterior surgical decompression and fusion. In patient with more than 3 months expected survival, anterior columnar reconstruction with the cage PMMA is appropriate in patient with kyphotic deformity and expected survival more than 6 months, and adjacent level involvement should be considered to reduce the risk of cage subsidence. This is the grading system, Bilski epidural spinal compression, cord compression. We have low grade and high grade. We have, this is the grading system of the compression of the spinal cord. 0 bone-only disease, and 1A epidural impingement without deformation of thecal sac. 1B deformation of thecal sac without spinal cord compression. 1C deformation of thecal sac without spinal cord abutment without cord compression, and high grade 2 spinal cord compression. With cerebrospinal fluid visible around the cord, and 3 spinal cord compression with no CSF leak visible around the cord. Hardware failure after fusion, it is more likely in patient with more than 6 levels of instrumentation. Asymptomatic hardware failure has been reported in older patients and may be more common in patients with junctional construct, and since more than 7 and longer construct, 6 to 9 level. Construct length and extent of surgery should be balanced with patient frailty. And for sacral metastatic tumor, sacral metastases are not common. Patient with asymptomatic sacral metastatic lesion with cortical erosion or compromise of the sacroiliac joint can undergo conventional or stereotactic radiosurgery with follow-up imaging to monitor for radiation-associated fracture. Sacral metastatic lesion with cortical erosion or destruction of the posterior suprasacroiliac joint should be evaluated for sacroplasty or transiliac transsacral fixation to prevent failure. And lesion involving the sacral ala and lobosacral junction require lumbopelvic fixation if there is evidence of instability. Sacroplasty versus fixation. Consolidation of sacroiliac lesion in patient with mechanical pain can cause sacral insufficiency fracture. It may also appear after radiation. Such problem can be solved by cementoplasty or application of transsacroiliac screws or a combination of both. Complex reconstruction technique may not be appropriate for metastatic pathology. Occasionally, lumbopelvic fixation may be utilized in isolated case involving the caudal lumbar vertebrae as well as the sacral ala. Minimal invasive surgery technique for metastatic vertebral tumor. Minimal invasive in spinal metastatic tumor aim is to minimize the impact of the negative effect of the surgery. The indication, the same indication, to decompress the neural structure, create a safe distance between the tumor and the neural structure, facilitating the radiotherapy, to restore stability, to provide a surgical diagnosis, and to reduce the tumor volume. It should be applied for 1 or 2 level disease. The procedure of minimal invasive surgery, decompression with small incision, suggested for 1 to 2 level decompression in case of radio-resistant tumor, and we can do short, median, or paramedian incision, and this could be combined with percutaneous screws. Endoscope-assisted surgery. Endoscope-assisted anterior reconstruction can be done. It provides a clear, wide-angle view in depth and combines well with other modality. Percutaneous screw fixation, they can be used alone or in combination with the compressed surgery. And vertebroplasty, injection of PMA under fluoroscopy guidance, reinforce the bone, supporting the anterior column. Methyl methacrylate has also an anti-tumor activity. This procedure may be combined with decompression and or percutaneous screws, and vertebroplasty provides pain relief, and a biopsy can be taken simultaneously. Radiofrequency ablation of tumor under CT or fluoroscopy guidance can relieve pain, reduce analgesic, and provide CO2 reduction. It is recommended in expected lung survivors more than 6 months that are contraindicated for open surgery. More than 3-level application is not recommended. Radiofrequency ablation and laser interstitial thermal therapy for thoracic lead and lumbar metastatic lesion are currently under investigation in clinical trials. And radiofrequency and lead increase the risk of vertebral body collapse post-treatment and should be combined with vertebral augmentation and or instrumented fusion as appropriate. What are the recommendation? I will summarize the recommendation of the WFNS Spine Committee for the clinical evaluation, diagnosis, and decision-making for metastatic spine tumor. First, a high index of suspicion for early detection and diagnosis of spinal metastasis in cancer patient and adult patient more than 60 years presenting with new onset fracture and neurological and or neurological deficit is recommended. Pain, the second recommendation, the pain is the most common symptom in patients with spinal metastatic, closely followed by motor radiculopathy. The origin of pain can be multifactorial, owing to local tumor-related pain, nerve root irritation, or pain due to spinal instability. The third one, blood and low bowel symptom, are present in more than half of patients with spinal cord compression at the time of diagnosis. And the fourth, an effective treatment for spinal metastasis should be able to achieve pain relief, tumor control, prevention of neurological compromise, and treat instability. The fifth, separation surgery combined with stereotactic radiosurgery is an effective treatment for spinal metastasis. What are the recommendation for the surgical option for metastatic spine tumor? The recommendation, the instability criteria, the spinal instability neoplastic score is an effective tool for evaluating the spinal instability and has resulted in improved uniform reporting of spinal instability criteria in metastatic tumor patient. The SINS score has good reliability across multiple specialties, particularly in experienced spine surgeon, and may improve referral of unstable spine patient to surgeon. However, its utility for non-spine practitioner is less clear. The decision to operate should not be based solely on SINS, as there are multiple other factors, including number of level of disease, tumor type, prior treatment history, patient frailty, and life expectancy. For the cervical and craniovertebral junction metastatic vertebral tumor, the option for surgical planning for cervical and cervico-craniovertebral junction metastatic vertebral tumor should be done using prognostic scoring system. Metastatic disease of the junctional area of the cervical spine will need robust and more frequent surgical stabilization. In craniocervical junction metastatic tumors, posterior instrumentation, including occiput, may be sufficient for stabilization, pain control, and neurological preservation. Complication of surgery of cervical and craniovertebral junction metastatic tumor are approximately 25%. Anterior surgery tend to have more complications than posterior surgeries. Prognostic factor for postoperative overall survival are tumor histology, preoperative disease progression, status, postoperative radiotherapy, and chemotherapy. For the thoracic and lumbar and sacral tumor, asymptomatic patient with metastatic lesion in the thoracic, lumbar, spine, and sacrum generally do not need surgery. Patient with high risk of vertebral compression fracture after radiation or chemotherapy may be considered for pre-treatment vertebral augmentation. Palliative radiotherapy alone may stabilize or improve neurological deficit of patient with spinal cord compression. SCORE2 and SCORAD3 randomized trial, both single fractionated radiotherapy and multi-fractionated radiotherapy improved ambulatory status at 8 weeks in patients with metastatic spine disease. Thoracic and lumbar metastatic lesion causing severe mechanical pain or instability require stabilization. Anterior column reconstruction should be considered in patients with long-term survival. Construct length and extent of surgery should be balanced with patient frailty. Thoracic and lumbar metastatic lesion with significant epidural cord compression from tumor resistant to conventional external beam radiation should undergo decompression with or without instrumentation prior to radiotherapy. Sacral metastatic lesion with cortical erosion or dissection of the posterior superior sacroiliac joint should be evaluated for sacroplasty or transiliac transsacral fixation to prevent fracture. Lesion involving the sacral ala and lumbosacral junction require lumbopelvic fixation if there is evidence of instability. For the minimal invasive surgery and percutaneous technique, MIS may be considered in the treatment of patients with spinal metastatic disease. MIS in patients with spinal metastatic has potential to achieve the goals of the standard surgery while reducing the hospital stay, providing faster recovery, and reducing the complication. The MIS may provide an alternative surgical option which may be applied in frail patients with spinal metastasis. What are the recommendations of the complication avoidance, rehabilitation, pain therapy, and palliative care for patients with metastatic spine tumor? Preoperative assessment for complication following surgery in patients with metastatic spine tumor. The tumor should include estimation of Karnofsky score, primary tumor, number of spinal and visceral metastases, as a score, and the preoperative hemoglobin value. There is evidence that advanced age more than 65 years is a significant risk factor for complication in treatment of patients with spinal metastases. Preoperative as a score of 3 and 4 increases the risk of medical and surgical complication in patients with spinal metastases. Surgical treatment planning in this patient needs additional consideration in respect of duration and invasiveness of surgery and estimated blood loss. Patients who underwent surgery for spinal metastases with greater blood loss have increased likelihood for cardiovascular events, pulmonary insufficiency, and cerebral events. Therefore, these patients need careful monitoring of these potential postoperative complications. Early postoperative mobilization and multimodal pain management are encouraged for high-risk patients with spinal metastases. Pain management and palliation in spinal metastases should be performed as indicated by the WHO analgesic ladder, appropriate for the severity of pain, starting with non-opioid, weak opioid, followed by strong opioids. The opioid of first choice for moderate to severe cancer pain is oral morphine, with a different opioid to be considered in the absence of adequate pain control or in the presence of unacceptable opioids side effect. IV PCA may provide timely, safe, and useful analgesia for patients with severe breakthrough pain. However, clinicians need to closely monitor the delirium and toxicity in advanced cancer patients. Bisphosphonates may be considered for the treatment of patients with bone metastasis with a good prognosis, especially when pain is not localized or radiotherapy is not readily accessible. In conclusion, with the advancement in cancer treatment and generalized increase in life expectancy, the incidence of spinal metastasis is actually increasing. Surgical treatment for spinal metastatic disease can involve a variety of options with the goal of decompression neural element and or stabilization of the spinal column to improve the quality of life. Numerous scoring scales such as SINS and criteria such as NOMS have been developed recently to help clinicians to provide uniform and evidence-based practices to improve patient outcomes. Separation surgery actually with stereotactic radiosurgery and systemic therapy should be used. And here we present some cases. This is a 60-year-old male, heavy smoker, complaining of dorsal spine pain with claudication, and the thoracic CT scan showed a posterior mass of D7 with intracannular extension and with spinal cord compression. And the CT scan of the lung we have in the lung cancer. This is metastasis, spinal metastasis in the posterior arch of D7 of the lung cancer, should be treated by decompression and stereotactic radiosurgery. Another 34-year-old male presented with complete paraplegia and the MRI showing this dorsal metastasis, and the patient had cancer of the testicle, and this is a metastasis of the testicular metastasis, should be treated by separation surgery and radiotherapy. Another male, 57-year-old male with dorsal pain and the only involvement of the vertebral body without cord compression, and the patient complaining of pain without neurological deficit, and neurological examination normal, can be treated with radiotherapy alone. And thank you for your attention.
Thank you very much, Professor, for this nice presentation. Please, Professor Raja, if you have any comments.
Yes, thank you, Dr. Mahdi, regarding the presentation of the whole spinal metastasis, which is really a very grave issue. If we are comparing to the CNS mets or the tumors, compared to the brain, the spinal metastasis is a very problematic issue. Because in the brain, either the patient survive or not, but the patient cannot suffer a lot of the pain which a patient can have during the progress of and the course of the spinal metastasis. You have shown few of the MRI, which was clearly defined metastatic tumors because both the vertebral bodies and the intervertebral disc spaces were intact. So it is a clear picture of the spinal metastasis, spinal met in a single unit, and there is no any question of the another pathology. But sometimes we found many cases with the early spinal, maybe it's a metastasis, but when the patient comes in third world country, there are the tuberculosis, and also in the females, osteoporotic collapses is also a challenge. And when the patient comes, and if there is no relief up to a period of the time, we found that is there any problem of the tuberculosis inside, or infective, or a neoplastic, or the met problem. For that, routinely we get the bone scan, and if the bone scan is not satisfied, then we go for the PET scan, which is non-invasive, or the CT guided biopsy. So particularly in our setup, where the Pakistan is a poor country and the patients are poor, so the matter of affordability always comes in front of us when we see these patients. If they have a frank metastasis, these patients are no, they are frank and they understand. We understand the patients having the metastasis, but those cases whom the MRI is also not significant, they are not properly delineating the disease like the METs, then these are the patients, and also lot of the female patients who is having the collapses and at the age of the 50 or 60. So more commonly, they presented as the collapses of the because of the osteoporosis rather than a metastatic tumor. But sometimes it is again very difficult without getting the pathology. We are dealing them, but the pain is not subsiding. Then we get the bone scan or the PET scan, and finally the CT guided biopsy, so that we should understand the nature of the problem, if it can be turned out to be a METS. So we have a lot of the patients, and again, the METS is a much problem, and the treatment of the surgery is very difficult in the more than one level disease, and radiation therapy is also not suitable, and particularly in our setup, the fixation is not routinely be performed because either the patients is reluctant for the fusion and the instrumentation, or secondly, they cannot afford. So I have visited in Germany. So I have been worked with Dr. Dr. Majid Sami, and one of his fellow whom I worked in Hanover, and he was doing the spinal surgery. So it was the routine in the Germany that the females with the 75 to 80 years of the age, they also were under this were planning for the surgery and underwent the surgery for a single block metastatic tumor, which arises from the breast. So this is again the choices of the patients, and also the countries where the developed countries have the financial backup. They have these insurance companies. So routinely these things can be performed in the developed worlds. But when we are talking about the third world country and the countries like Pakistan, lower middle income countries, these problems also struck us for performing the routinely for the metastatic type of the problems in the spine.
Thank you, Professor. In our country, we have similar problems, as most of the patients are poor and they cannot afford instrumentation or surgery. And in metastatic cases, especially, the patient came in a very late stage, usually, and they usually also have osteoporotic spine. And so in these cases, most of the times we just send them to radiotherapy and give them anesthetic, as they don't tolerate surgery, as their condition don't tolerate surgery, and they have multiple levels with osteoporotic spines.
Radiotherapy, yes. In this case, we should do radiotherapy like the algorithm of NOMS, donc radiotherapy. Patient who do not tolerate surgery and with multiple level, yes, radiotherapy alone.
Because most of them they came in very late stage, they don't
Yes,
came early, so it is difficult to do surgery for them.
Yes.
If anyone have any questions to Professor Darmoul, please you can ask in the chat or raise hand to ask directly. Although the presentation was very thorough and very complete, but if anyone have any comments or any question, please you can go ahead. I don't see any questions. So, Professor Raja, would you like to conclude today's session?
Yes. Thank you so much, Dr. Ahmed, for conducting such type of the beautiful and very informative academic sessions online. And we are lucky to have a Skype nowadays, so that the whole of the world can be connected with the Skype, and we deliver the lectures, we listen the lectures, update our knowledge and skills by the net. And it was the initiative from the Yemeni Society that they have conducted. And this is, I think, the fourth module. So we are
Yes.
conducting, isn't it? Yeah.
Yes, Professor.
So this is a very good for the undergraduates and also for the postgraduates and also for the senior persons to again refresh their knowledge. And Dr. Mahdi, it was a wonderful talk about the whole of the spinal mats, and also you have presented the WFNS recommendations about the treatment and also about the complications, how we can deal. So all the listeners and particularly the postgraduate should have a good update of the knowledge regarding the what is the currently what is recommending and what is going on. So thank you so much, Dr. Mahdi.
Thank you. Thank you very
Thank you.
much.
Thank you very much, Professor. And we are lucky and honored to have experienced and senior neurosurgeons like Professor Mahdi Darmoul and Professor Yas to participate with us in our program. It's a great honor for us and a great experience to learn from your knowledge. Thank you all, and thank you everyone.
Thank you
so
very
much.
much.
Allah
Thank you.
Hafiz.
Thank you
Allah
so much.
Thank you, and see you all, inshallah, all next week, inshallah.
Another. Thank you.
I can see a question here. If Professor Mahdi, if you would like to, Dr. Abdul Karim Mansour, he is asking how to differentiate between metastatic or infected spine.
Metastatic and
Infection.
infection.
Yes.
The context of the infection is different from
Very
metastatic.
different.
The context, yes, is very different, and the biopsy will show us the nature of the primary cancer. The biopsy or the histology.
We start with the history. History is different between the
Yes,
infection and the
is
metastasis.
different.
There will
Yes.
be difference of the progression of the symptoms and
Yes.
also associated symptoms. And after that, we can do routine blood test
The
like
infection is
ASR,
acute
CRB,
with
and yes.
yes.
And if in difficult cases or cases, obscure cases, as you said, we can do CT guided biopsy and check.
Yes.
So that's good. So thank you, Professor, and see you all next week, inshallah.
Okay. Thank you. Thank you very much. Thank you.
Thank you, Professor.
Bye. Bye.